Managing hypertension in primary care. Clinical knowledge summaries CKS hypertension, not people with diabetes. Managing hypertension in primary care. Educational slides based on the CKS topic, hypertension, not diabetic, April 2012, and NICE Guidance, 2011, Hypertension, Clinical Management of Primary Hypertension in Adults. Key learning points and objectives. To be able to describe the benefits of lowering blood pressure. Outline which antihypertensives should be prescribed initially. Describe when to continue or stop a beta blocker. Describe how to adjust treatment. Recognize when referral or admission is required. If BP is very high in clinic, arrange same-day admission if BP is 220/120th of a millimeter of mercury or higher. BP is 180/110th of a millimeter of mercury or higher with signs of accelerated, malignant, hypertension, papilledema and/or retinal hemorrhage. Start antihypertensives immediately if no signs of accelerated hypertension and systolic BP is 180 mm of mercury or higher, or diastolic BP is 110 mm of mercury or higher. Management following ABPM and HBPM. Offer antihypertensive treatment if the person is younger than 80 years with stage 1 hypertension and has one or more of the following. Target organ damage, established cardiovascular disease, renal disease, diabetes, and/or a 10-year cardiovascular risk of 20% or more. Any age with stage 2 hypertension. Initial management for all people with hypertension. Assess and manage cardiovascular risk. Reinforce lifestyle advice such as stopping smoking, moderation in alcohol, salt, and caffeine consumption. Give advice on weight loss, if appropriate, lifestyle and non-drug measures. Advise moderation in alcohol consumption, moderation in consumption of coffee and other caffeine-rich products, reducing salt consumption, or using a salt substitute. Stopping smoking, offer referral to smoking cessation services. About local initiatives that provide support and promote lifestyle change, for example run by healthcare teams or patient organizations. Lifestyle and non-drug measures. Advise that sustained relaxation therapies may reduce BP, for example stress management, meditation. Information on self-care can be obtained from the Blood Pressure Association, www.psoc.org.uk. Consider offering referral for smoking cessation, exercise and physical activity programs, weight loss programs, dietary advice, benefits of antihypertensives in general. People using antihypertensives can expect to extend their life by between 8 and 11 months if they are 50 years of age. To extend their life by between 3 and 5 months if they are 70 years of age. Greater absolute risk reductions if they have higher baseline risks for coronary heart disease or stroke. Greater risk reduction for stroke than for coronary heart disease. Target clinic blood pressures. Target clinic blood pressures, BP. Aim for a BP lower than 140/90ths of a millimeter of mercury for people under 80 years. Aim for a BP lower than 150/90ths of a millimeter of mercury for people 80 years and older. Starting antihypertensives. If younger than 55 years of age, not of Black African or Caribbean ethnic origin, start an angiotensin-converting enzyme, ACE, inhibitor, or a low-cost angiotensin II receptor antagonist, ARA. If ACE inhibitors or ARAs are not suitable, start a low-dose thiazide-type diuretic or a calcium channel blocker, CCB. A beta blocker can be considered as initial treatment for younger people who cannot use or tolerate ACE inhibitors and ARAs. Women who might become pregnant or are planning a pregnancy. People with evidence of increased sympathetic drive, for example sweating. Starting antihypertensives. If 55 years of age or older and of Black African or Caribbean ethnic origin, any age, offer a CCB, or a low-dose thiazide-type diuretic. If a CCB is not suitable, for example edema or intolerant, there is heart failure, or a higher risk of heart failure. If aged 80 years and older, offer the same treatment as people aged 55 years and older. Take into account any comorbidities and other drugs being taken. For people with isolated systolic hypertension, offer the same treatment as people with both raised systolic and diastolic blood pressure, BP. On a beta blocker for another indication. If BP is well controlled and there is a compelling indication for a beta blocker, for example symptomatic angina, continue the beta blocker. There is no compelling indication for a beta blocker, discuss and consider adding or switching to another antihypertensive drug, according to the stepwise approach. Always gradually step the dose down if stopping a beta blocker. On a beta blocker for another indication. If BP is not controlled, consider continuing the beta blocker and adding a new antihypertensive drug according to the stepwise approach. If a beta blocker is being considered for long-term use with a thiazide diuretic, discuss with the person the benefits of treatment versus the risk of developing diabetes. Which antihypertensive? NICE recommend using an ACE inhibitor, an ARA, a calcium channel blocker, or a beta blocker that can be taken once a day, is generic, and minimizes cost. Calcium channel blockers. If a rate-limiting calcium channel blocker is being considered, once daily formulations of diltiazem or verapamil are recommended. Do not prescribe verapamil with a beta blocker. Risk of reduced cardiac output and heart failure. Diltiazem can be used with caution with a beta blocker. It has a smaller negative inotropic effect than verapamil. Monitor the person's pulse and blood pressure carefully due to the risk of bradycardia. Which thiazide diuretic? If already taking bendroflumethiide and BP is well controlled, continue treatment with this. If starting a thiazide-type diuretic, indapamide or chlortalidone are preferred because there is most trial data to support their use. NICE found a lack of trial data to support bendroflumethiazide, but could not confirm that it was ineffective. Follow up if being treated with lifestyle measures only. Follow up every 3 or 4 months, until blood pressure is well controlled, or antihypertensive drug treatment is started. Annually, when the blood pressure is well controlled. Follow up when starting drug treatment. Recheck BP every 4 weeks. If starting a thiazide diuretic, check urea and electrolytes, and the EGFR at baseline and every 4 to 6 weeks. If starting an ACE inhibitor or an ARA, check urea and electrolytes, and the EGFR at baseline and 1 to 2 weeks after starting treatment. If starting a CCB, no specific blood tests are required. Adjusting drug treatment. Use clinic BP to monitor response. If the person has a white coat effect, consider ambulatory or home blood pressure monitoring. If BP is not adequately controlled on the maximum licensed or tolerated doses of one antihypertensive drug. Check concordance. Ensure that the person is taking the maximum licensed or highest tolerated dose of antihypertensive medication. Consider secondary causes for hypertension and whether specialist advice may be helpful. Consider adding additional drugs in a stepwise manner. Adjusting drug treatment. If on monotherapy, add a second drug. If on an ACE inhibitor or an ARA, add a CCB. If the person cannot take a CCB, add a thiazide diuretic. If on a CCB or a thiazide diuretic, add an ACE inhibitor or an ARA. If the person cannot take an ACE inhibitor or an ARA, consider combining a CCB with a thiazide diuretic. If on dual therapy, prescribe a third antihypertensive such as an ACE inhibitor or an ARA, a calcium channel blocker, and a thiazide-type diuretic. Adding a third drug? NICE acknowledged that little evidence was available to guide clinical practice. The guideline development group concluded that the most straightforward choice was to recommend combining an ACE inhibitor or an ARA plus calcium channel blocker plus thiazide-type diuretic, adding a fourth drug, if BP is not controlled on 3 drugs. If serum potassium is greater than 4.5 millimoles/L, consider increasing the dose of a thiazide diuretic. 4.5 millimoles/L or lower, consider adding another diuretics such as low-dose spironolactone, off-label. If further diuretic treatment is not tolerated, contraindicated, or ineffective, add an alpha blocker or a beta blocker. Again, evidence is lacking to guide treatment choice. Adjusting drug treatment. If BP is not controlled on 4 drugs, seek specialist advice. May not be possible to reach target BP. When to refer? Consider referral if BP is not adequately controlled on optimal primary care treatment, or secondary hypertension is suspected which cannot be managed in primary care, or postural hypotension is symptomatic, or systolic blood pressure decreases by 20 mm of mercury or more on standing up, or there is a consistent difference in blood pressure readings between arms of more than 0.20 of a millimeter of mercury, or white coat hypertension is suspected and ambulatory blood pressure monitoring or home monitoring is not available. When to admit? Admit, or refer immediately, those people with accelerated, malignant, hypertension. BP is 180/110 of a millimeter of mercury or higher with signs of papilledema and or retinal hemorrhage. Hypertensive encephalopathy. Suspected for chromocytoma and severe hypertension. Severe hypertension and impending vascular complication. Summary target clinic BPs, offer lifestyle advice. Lower than 140/90 of a millimeter of mercury if less than 80 years. Lower than 150/90 of a millimeter of mercury if older than 80 years. Offer lifestyle advice. Initially, and then periodically, to people being assessed or treated for hypertension. If younger than 55 years of age, not of Black African or Caribbean ethnic origin, start an angiotensin-converting enzyme, ACE, inhibitor, or a low-cost angiotensin II receptor antagonist, ARA.